Hi, this is Tim Stump from Technique Peak. Today I'll be discussing the concept of training movements versus muscles. So training movements, the best place to do this is during the remodeling phase of rehab. This is best done at 8 to 12 weeks after the person is recovering from either an acute injury or surgery. The person who probably knows the most about this is Richard Schmidt from UCLA. He's a motor learning theorist who has identified 6 basic human movement categories. First one is squat, which is pretty self-explanatory. Second one is bend. And as therapists and athletic trainers, we think of this as your posterior chain musculature, or hip hinge is a common term. Third category would be lunge. So in our world, I kind of think of single leg activity. And then when it comes to your upper body, he talks about gross movements of pushing and pulling, all right? And then the last category would be twist. And this could be anti-rotational activities, but I just, in my mind, think of it as core, all right? So with these 6 categories, it really gives the clinician a template which to design a very uniform or balanced program. You're not missing any aspect of the training program. When we're dealing with lower extremity patients in rehab, whether it's knee or hip, the 3 big ones that you're talking about are squat, bend, and then lunge. So the squat is any closed kinetic chain exercise that's bilateral, multi-joint in nature. So ankle, knee, and hip. Obviously leg pressing, any of the various forms of squatting would fulfill this category. The second one is the bend. So we're trying to train your posterior chain muscles, whether it's the hamstring, glutes, and low back, lumbar extensors, spinal erectors, to work together in unison in a synchronized manner. So that could be bridging, that could be an RDL, glute ham raise would all satisfy that category. And then the third one for the lower extremity would be lunge. Obviously lunging in various planes of motion. You would start from simple and then get more complex. But also in that category you can include your step-ups, split squats, whether it's rear elevated, split squat, step down, lateral step down, things of that nature. When we're talking about upper extremity, whether it's elbow or shoulder, he has the category of push and pull. Now, those 2 categories can be subdivided into the horizontal and the vertical plane. When we think about our shoulder patients, obviously pushing or reaching overhead is going to be a little bit more advanced, and they may not progress to that, or at least you need the prerequisite mobility to get into that position. When putting this all together, at the very end, you still want to include core and twist. There's lots of evidence in addressing deficits in the core with ACL patients. There's lots of evidence in addressing core musculature in the throwing athlete. At the very end of your program, this is where I think the clinician is best suited to put in their isolation rehab exercises. This is where you can address muscle imbalances or any other deficits. Hopefully you find this is helpful in treating your patients. Thank you.